Today's webinar, in my mind, reflects what IFMIS is all about, bringing researchers together.
Good afternoon also on my side. My name is Elena Tsourdi and I am an endocrinologist in the University Clinic in Dresden and also the co-chair of today's first webinar of the series together with Professor Langdahl. I am very happy that today we could acquire three excellent speakers to delve into the sclerostin story. And this is a webinar which really covers all facets of the Wnt signaling pathway and sclerostin, namely basic, translational, and clinical aspects. And so I will now turn back to Professor Langdahl to introduce the first speaker.
Thank you, Elena. So our first speaker is Natasha Appelman-Dijkstra. She's an internist, endocrinologist specialized in osteoporosis and metabolic bone disease and calcium and phosphate disturbances. Natasha received her PhD in 2015 from the University of Leiden, and since 2016, she has been head of the Center for Bone Quality in Leiden. Her clinical and research interests are osteoporosis as well as rare bone diseases such as sclerosteosis and fibrous dysplasia. So please, Natasha.
So thank you very much for this very kind invitation to speak here, for this very kind introduction. So I will give the first talk and I will basically speak a lot about the phenotype of human sclerostin deficiency, namely the two diseases, sclerosteosis and Van Buchem's disease. These are my disclosures. To give you a bit of background information about the unraveling of the Wnt signaling pathway and its importance in bone, I will shortly introduce you to two other rare diseases which were the basis for this specific unraveling of the Wnt signaling pathway. The next speaker, Professor Rauner, will provide an excellent talk about the basic science and animal models around sclerostin and the Wnt signaling pathway. So I will not touch upon that topic, but we'll keep it clinical. So in this case, a rare disease acted as a human experimental model where bone fragility went hand in hand with specific extraskeletal features. In the osteoporosis pseudocleioma syndrome, skeletal fragility is accompanied by the developmental defects of the eye. In the picture of this original publication, you can see in picture A the deformities of the lower limb of a 40-year-old affected female patient. You can also see in picture B, the vertebrae are also quite affected there. And I would like to draw your attention not to the eye, of course, in picture C, which is also affected by the pseudocleioma syndrome, but to the pictures D and E, which demonstrate the bone iliocrest bone biopsies of the healthy 2.5-year-old child, but an E, an affected child with the osteoporosis pseudocleioma syndrome. You can see that there's a remarkable difference in the amount of trabecular bone and also in the thickness of the bone. And in this case, the bone of these patients are, of course, more fragile and more fractures occur. The underlying cause of this specific disease was found to be in a mutation in LRP5. At the same time, while unraveling the specific genetic factors influencing bone mass, a family was characterized with included individuals with exceptionally high and dense bones and were otherwise phenotypically normal. Although you can appreciate in the picture B from this publication that there's already a bit of enlargement of the jaw. This mutation was also again found to be LRP5 mutation. So LRP5 was rather important in increasing rather low bone mass, but also very high bone mass. And thus the unraveling of the Wnt signaling pathway began. It was found that in two groups that were similarly researchers to in sclerosteosis, but also in Van Buchem's disease, that they found there was an underlying problem within the synthesis of sclerostin. So sclerosteosis is an autosomal recessive sclerosing bone dysplasia characterized by progressive skeletal overgrowth. The majority of the affected individuals have been reported in the Afrikaner population in South Africa, where a high incidence of the disorder occurs as a result of a founder effect. a new mutation in a gene called SOS was identified. SOS encodes for sclerostin, and in sclerosteosis, absolutely no sclerostin is synthesized. While in Van Buchen's disease, there is still somewhat production of sclerostin due to the fact that the mutation is found a bit further along the line. Using an extended Dutch inbred Van Buchem family and 2 inbred sclerosteosis families, both diseases were unraveled, and also the function of sclerostin in the Wind signaling pathway of bone was discovered. So what happens with sclerostin and the Wind signaling pathway? In bone, sclerostin is secreted by osteocytes, and in this way, the osteocyte regulates bone formation by inhibiting the osteoblast by binding to LRP56 with its co-receptor LRP4 and frizzled. Lack of sclerostin will give continuous activation of beta-catenin and transcription, leading into osteoblast activity, and therefore there is an ongoing bone formation rate. So after the discovering of these pathways and the underlying mechanisms of disease, a joint study was performed to further characterize patients and carriers of both the disease of Van Buchem and sclerosteosis. These extremely rare diseases are centralized by nature in South Africa and the Netherlands. Sclerosteosis patients are mostly found in South Africa, and the white Afrikaners, where specifically the disease is seen, are thought to originate from the Dutch, while the Dutch were sailing across the sea, they landed in Africa and there started their own communities. Van Buchem originates in a small fishing village within the Netherlands, which used to be an isle for quite a long time, also allowing to be very isolated in the past. So the clinical work, which I'm going to present, a lot of it has been done by Dr. Anton van Lierop, which you can all see over here, and also with Dr. Herman Hamersma, was one of the ENT surgeons in South Africa who devoted his life to taking care of these patients with sclerosteosis. So sclerosteosis was first described in 1929. It's an autosomal recessive disease, and it's characterized by progressive bone overgrowth, cortical hyperostosis, entrapment of cranial nerves, and raised intracranial pressure, and syndactyly. Due to the tall stature of these patients, in the past, associations with growth hormone excess were thought and postulated, but these were ruled out. On this picture, you can clearly see the differences between a normal skull and the skull of a patient with sclerosteosis. You can see here there's a thick widening of the mandible, and also there are a lot of bony overgrowths of the skull, which can be seen there. So although most patients have been reported into South Africa, there are also a lot of variants found outside of South Africa nowadays. There are reports from patients from Brazil, the United States, but also from Europe, Egypt, Senegal, and India and China. So more and more mutations have been identified. So in Van Buchen's disease, another name for it is hyperostosis corticalis familiaris generalisata. And this was firstly described in 1955 by Dr. Van Buchem, who was an ENT surgeon in Groningen. The phenotype is somewhat similar to sclerosteosis, but without the syndactyly, and the phenotype seems to be less severe, although increased intracranial pressure can occur with Van Buchen's disease. It's less likely to happen within this specific disease because there's still somewhat production of sclerostin. Here you can see the family tree of the affected family and a remarkable thickening of the skull and sclerosis hyperostosis of the bone of a patient versus control scan. So both diseases are characterized by an increase in bone formation and in bone mass, but this is good quality solid bone. So in other words, is bone quality maintained in sclerostin deficiency? You can see here the bone biopsy over here from a healthy person, where you can distinguish the difference between cortical bone and trabecular bone. And you can also see the bone marrow being present there. And on the other side, there is a bone biopsy specimen for a patient with sclerosteosis. You can hardly see any bone marrow being present there, and also no difference. You can hardly see the difference between trabecular bone and the cortical bone. You can also imagine that it's really hard to obtain such a bone biopsy, and it's really not easy to do so. And is this increased bone mass with also with intact structural properties? So you can see that the bone has a normal structure with a woven, normal woven appearance on polarized light and clear formation of osteons. The matrix mineralization is lower with an increased heterogeneity and lower crystallinity. And anecdotally, patients hardly break. We have encountered in all the follow-up studies one patient who had an extremely severe accident on a motorcycle, and he did break a bone. But we only encountered 2 younger patients who did have a fracture during childhood, but not in adulthood. Also, anecdotally, patients with Van Buchen's disease do not like to swim because it takes them a lot of effort because their bones are quite heavy and they have difficulty floating. So the effect of sclerostin seems to be gene dose dependent. For this, we combined the results of the patients with the carriers and healthy controls of both the Van Buchen's disease and the sclerosteosis patients. And you can see that the patients who have the more severe phenotype, the sclerosteosis patients, have the lowest levels of sclerostin, while the Van Buchen's carriers who have the less phenotype have the highest of the sclerostin, and of course the controls are there to compare. If we look at bone mass, we also see that this is sclerostin level dependent. The closed circles here are the patients, which all have very high bone masses above a Z-score above 7 or 8. And you can see that the carriers do exhibit somewhat of a phenotype where they do have a bone mass which exceeds a Z-score above 0, and some of them even have a Z-score above 4. So although they're clinically not affected by the disease, they do exhibit higher bone mass. So when we compare both diseases, you can see there are a number of differences between them. Especially syndactyly is present in sclerosteosis and not in Van Buchem. Facial distortions and facial nerve palsy can be present in both, but more often in sclerosteosis patients. Both patients groups suffer from hearing loss. And the lumbar BMD Z-scores and femoral neck BMD Z-scores seem to be a bit higher in sclerosteosis patients compared to Van Buchem's. It is noted that in patients with sclerosteosis, they are taller than their peers, but it's also due to the fact, if you look at absolute numbers of height, Van Buchen's patients and sclerosteosis patients have the similar height, only because of the fact that most of Van Buchen's patients live in the Netherlands. Their peers are also tall. So that's one of the reasons that we don't consider them to be very tall indeed. What you can also see at the bottom line of this table is that bone formation markers are elevated in both diseases, and this is throughout lifespan. So when we look in follow-up of these patients, and especially in the more severe phenotype of sclerosteosis patients, we did a chart review of all the patients who were known in South Africa with sclerosteosis. And there we could see that the mortality is usually related to coning of the brainstem. There also are perioperative complications, because you can imagine if you do a surgery, especially in craniotomy in these patients, it can be very difficult and can be related with a lot of complications. But there were no particularly distinguished other problems causing early death. So what we saw in sclerosteosis is the Kaplan-Meier curve, is that the increased intracranial pressure does suffer for a lot of patients throughout lifetimes, and this requires the positioning of VP drains and also repetitive craniotomies in these patients. So it comes along with a high morbidity. So the observed morbidity and mortality in sclerostin deficiency, especially in sclerosteosis, was related to the bone mass related comorbidity, so nerve compression. They often need hearing aids, facial palsy, and the increase of sudden death was mainly seen in sclerosteosis. And until today, no data were available in Van Buchen's disease. There were no reports on other related morbidity and mortality, especially not, of course, in light of the coming of the romosozumab story for cardiovascular problems. But again, these were small patient numbers, of course, so you have to bear that in mind. So we recently visited the Van Buchen's population again. So we were able to retrieve 13 patients of the original publication to see after 7 years of follow-up if there were any particular items arriving. So what we saw is that bone mass appeared to be stable during the follow-up period, which is, of course, for the patients, somewhat good news. And what we also saw is that the bone formation markers still remained at the same level. So they didn't drop, they just, because there's, of course, more bone, the bone formation rate was also a bit higher than normal. We also did a full workup for cardiovascular disease, which included EKG, blood pressure measurement, cholesterol levels, glucose levels, but we didn't find any particular differences there. So the clinical features in Van Buchen's disease follow-up, we saw that the hearing loss is progressive. There were 2 patients with a documented increase in intracranial pressure out of 13, which is a bit higher than what was expected before. And there also seemed to be a continuous growth of the cavalian bones, because a lot of the patients did complain about continuous bony overgrowth, especially around the hearing aids. Increased intracranial pressure was treated very well with craniotomy or with the placement of VP drains. And again, no signs of early vascular disease were found. So in conclusion, the morbidity and mortality in patients with sclerostin deficiency syndromes are related to the increased bone mass and not with other problems like an increased risk for malignancies or increased risk for cardiovascular diseases. In these small patient groups, no other comorbidity, especially diabetes or cardiovascular diseases, have been identified so far. And survival into old age is unusual in sclerosteosis in the past because of sudden death of coating of the brainstem or perioperative complications. So the mean age in this chart review was 33 years. But however, since operating techniques and follow-up procedures have been improving, it's very well to be expected this will be increasing in the coming years. So the sudden death due to impaction of the brainstem have not been reported in patients from Van Buchem, although these patients can suffer from complaints from increased intracranial pressure like headache or nausea. Well, we have undertaken a lot of effort to produce a drug for patients with low bone mass. So perhaps in the future, we also should focus to see if we can undertake an effort to attenuate the effects of sclerostin deficiency in these patients with sclerosteosis and Van Buchem. And hereby I would like to conclude my talk. Thank you very much for your attention. And I'll, of course, be open for any questions afterwards.
Thank you very much, Dr. Appelman, for this very comprehensive overview of both diseases, and also especially appreciated the personal experience of Leiden. Also quite fascinating that your group went to South Africa, or members of your group also, to characterize this patient so closely. So thank you. And I would like now to introduce the next speaker, Professor Martina Rauner, who is a professor of molecular bone biology in Dresden and also the co-director of the Bone Lab in Dresden. Martina Rauner is, I think, predestined to give this talk because of her groundbreaking work in Wnt signaling pathway, also including a lot of transgenic models in sclerostin and also other Wnt inhibitors. And we are very much excited to hear her talk.
Okay, thank you so much, Elena, for the kind introduction. And it's really also my great pleasure to be involved in this webinar today. And yeah, in the next few minutes, I want to highlight a few things more into the mechanistic details maybe. And also I want to mention that I will really mostly or just focus on bone, because in the past years, there was also a lot of research going on sclerostin and other tissues, but today I think there's in 20 minutes, it's even difficult to cover just the bone aspects. So this is just a brief overview of the talk today. So I want to start off with looking into sclerostin knockout mice, or also transgenic mice, looking at what it does to the healthy bone in fracture healing and in loading, unloading, as that is very critical for the osteocyte and sclerostin. And then we will also look into what we learned from models with sclerostin antibodies. And I want to finish off looking at which LRP receptors are actually involved in mediating the effects of sclerostin. What could be explanations for the waning effect that we see, I think, in mice, but also in humans. And then I will finish off with a short summary. So I think the first part we can go over quite quickly, because I think the mouse phenotype in terms of the bone recapitulates the one in the humans quite well. So I think here it's even sufficient just to look at the micro-CT images, and you see that there is really a very high trabecular bone mass. The cortices are very thick. And what is interesting here is maybe that this is the same for males and females. The periosteal perimeter is increased, and also the cortical area is increased in general in these animals. And what was already mentioned in the talk just before is that this increased bone mass is not only more bone of low quality bone, but it's actually high quality bone. So these animals also have a very high bone strength. So these mice are very mechanically competent, if you like. And this is again gender unspecific. So we see that in males and females. So looking into how this increase in bone mass comes about, there have been, of course, histomorphometric studies to look into bone formation and bone resorption. And what is very striking in these animals is this marked increase in the bone formation rate. And on the one hand, just looking at the osteoblasts themselves, we see that the number of osteoblasts and the surface that is covered on the bone by osteoblasts is increased, and that is also reflected here in the mineralizing surface per bone surface. But also the mineral apposition rate, which somehow reflects osteoblast activity, is increased, at least in the males. Only shows a trend in the females, but altogether this results in a really highly increased bone formation rate. And it's quite interesting to point out, I think, that in these very first studies, the effect that we now know also on bone resorption was not that clear. I think in the males there was no difference here, even though the females showed a trend to decreased osteoclast surface, but we will touch upon this aspect a little bit more later. Yeah, the increased bone formation rate, again, is not only true for trabecular bone, but here we also see the periosteal and the endocortical areas of the cortical bone. And again, in both cases, in both males and females, we see these very stark increases. Moving on to fracture healing, this is also quite interesting aspect where I think in the x-rays already you see that the fracture callus is much more dense in the SOS knockout compared to the wild type. And again, this leads to a more mechanically competent fracture callus that is stronger as compared to the wild type. And similar to also the normal bone maintenance, also in the fracture healing aspect, we see that the number of osteoblasts is increased at earlier and later time points, also resulting in an increased bone formation rate again. And finally, this improved fracture healing in the SOS knockout mice was also demonstrated by a different group that in general showed the same results. So also that fracture healing is somewhat accelerated in the SOS deficient animals, again, also due to increased osteoblast numbers. And here they also show that this is mediated via increased Wnt signaling, here demonstrated by immunohistochemical staining of activated beta-catenin. So this is also a finding that you would expect if you inhibit or knock out sclerostin, that you would have increased Wnt signaling, and this is in fact the case. I would like to lose just 2 or 3 slides about loading and unloading, because we know that sclerostin is really mainly expressed in mature osteocytes. And we also know that osteocytes are really the mechano-sensitive cells in the bone. And as such, there were studies to look at how sclerostin is regulated by loading and unloading, and if maybe sclerostin is one of those critical mediators to sense or to react to mechanical loading. So here's one study where loading experiments have been performed on the tibia. And you can see that the loaded condition drastically decreases sclerostin expression, which is quantified here. And we all know that loading is good for bone, and it leads to an anabolic response that you can see here. This is just across different regions of the tibia, but in the end, we always end up with a very nice increase in the bone formation rate on loaded bones in wild type animals. But this is not the case at all if you have mice that overexpress sclerostin. You see that there is a markedly blunted anabolic response to loading. And if we look the other way around, we also know that unloading is detrimental for bone. So again, in a wild type mouse that is unloaded, you will have bone loss that is also partly mediated by a decreased bone formation rate. However, in the sclerostin knockout animals, the unloading does nothing to the bone, so there is still very active bone formation going on, and these mice are completely protected. So this means that sclerostin is really a key regulator of the mechanic competence of bone. So I think one of the questions then is like, for this very marked increase in bone formation, where does this come from? Is it osteoblast proliferation? Is it increased function? Is it reduced death? What is the mechanism? And there were some studies that looked into this. Here's one of the first studies that actually looked at sclerostin also in vivo, but here they have performed in vitro studies with osteogenic cells, and they found that if you treat osteoblast cells with sclerostin, that you can reduce their proliferation rate, and also their mineralization capacity is reduced. And this is something that you can also find in vivo, again, looking at overexpressing mice of sclerostin where you have osteopenia. And in this graph here, we see that they also have low bone strength. And here again, looking at the calcium labels, you see that the calcium labeling, which indicates bone formation, is very much decreased. There are some newer studies that have used lineage tracing to look into what now really happens to the osteoblasts and also their precursor cells. And here I first want to start with the one that looked at the bone lining cell. I think the bone lining cell in general is maybe a still quite understudied bone cell. But here they have looked at really the morphological characteristics of what we know how a bone lining cell would look like, and that is rather flat, as compared to an active osteoblast that has this cuboid shape. And here they treated mice with a sclerostin antibody and then calculated the thickness of these cells that are lining on the bone surface. And they found that with the sclerostin antibody, the cells are much thicker compared to the untreated animals, suggesting that sclerostin inhibition turns these bone lining cells into active osteoblasts. And then there were some more very interesting studies, again, using lineage tracing to look at the skeletal precursor cell that are here defined as SOX9 positive cells. And again, here mice were used that were treated with the sclerostin antibody. And here you can see with the arrows also indicated here that 7 days after the antibody treatment, but also later on, there was an increased number of these skeletal precursor cells in the bone. And the paper went on to show that these stem cells then also really differentiate into osteogenic cells. So we're not going to go into detail here, but if you're interested, it's really worth reading this up. I think another point of the study is again to show that this increase in the percentage of these skeletal precursor cells was strongly dependent on Wnt signaling activation, because in one set of experiments, they also used mice that had a deletion of beta-catenin. And in this case, this increase in the precursor population was completely abolished. So this shows again that it's really mediated by activated Wnt signaling, that sclerostin inhibition can increase the numbers of skeletal precursor cells. Okay, moving on now to some disease models. And here I want to really focus on ovariectomy as one of the most important models for postmenopausal osteoporosis. And in one of the first studies here, they have taken rats that were ovariectomized for 2 months. And this is then what they show here as the baseline. And then the ovariectomized group then either received the sclerostin antibody or vehicle control. And you can see again at both sides, the vertebra, but also femur and tibia, that there were very nice increases after administering the sclerostin antibody. And again, looking into the histomorphometry, as expected, we see this increase in bone formation rate quite drastically. But I think maybe this was one of the first studies also in the preclinical models to show that there was also a significant reduction of the osteoclast surface per bone surface. So I think this was maybe one of the first studies to suggest that there might be a dual mode of action of sclerostin. And studies have then looked into this in a little bit more detail, using here an osteocyte-like cell line to look at how this reduced osteoclast numbers could be explained. And here they have taken the MLOY4 osteocytic cells and treated them with increasing doses of recombinant sclerostin. and they saw that the rank ligand OPG mRNA ratio was dose-dependently increased. And when they've taken these pre-treated cells into culture and then added PBMCs as precursors for osteoclasts, they found that if the cells have been pre-treated with sclerostin, that they produced more or were able to induce more osteoclasts than without. And finally, they also treated these cell cultures with OPG, which completely abolished this increase in osteoclasts, showing that this is really mediated via the rank ligand OPG system. Another interesting finding I want to highlight in this context of ovariectomy is the increase in bone marrow adipose tissue that we know happens also with ovariectomy. And also in this case, with the sclerostin antibody, you can see that there is a marked reduction again in the bone marrow adipose tissue. In fact, it actually stayed as low as the sham vehicle control. And this is not only true in the context of ovariectomy, but in fact, the previous study and also this one here show that either treating healthy mice with the sclerostin antibody leads to a decreased bone marrow adipose tissue, as shown here with the osmium tetroxide, but also sclerostin deficient animals have less bone marrow adipose tissue. And the lineage tracing study that I showed you before has also looked into the adipogenic precursor cells. And what you can see here labeled in red is again that all of these precursor cells, these adipogenic precursors, are severely reduced in the group that was treated with the sclerostin antibody. So I think this shows that sclerostin inhibition also targets very early the skeletal stem cell to really push them towards osteogenesis rather than adipogenesis. Yeah, here's just a list to show that sclerostin inhibition is very potent and it can improve bone mass, I think, in almost all kinds of scenarios of bone loss. So in diabetes, osteogenesis imperfecta. So a lot of studies have been conducted. But as usual, there's always one exception to the rule. And in this case, we have here osteoarthritis. So in this case, the antibody hasn't been used. So these are just studies from a SOS knockout mouse. But here was suggested that subjecting these knockout animals to a model of osteoarthritis actually led to more severe osteoarthritis as compared to the wild type animals. And also in the context of rheumatoid arthritis, there was one paper that showed that sclerostin may interfere with TNF signaling. And they showed that in the case of sclerostin inhibition, there was a more severe extent of inflammation. So suggesting that I think more studies are still needed to look into these aspects of arthritis, no matter if inflammatory or not so inflammatory, like with osteoarthritis. But somehow the cartilage seems to be reacting a little bit different, even though the sclerostin knockout animal in the healthy state does not show any cartilage abnormalities. But maybe in the context of disease, this is a little bit different. Okay, then maybe a few slides about which receptor is actually involved. So we heard earlier also that sclerostin can bind to LRP5 and 6 and thereby prevent the activation of Wnt signaling. So there have been some studies to look at too if LRP5 and 6 are equally important. And as we have also seen in the presentation before, the high or the gain of function mutations of LRP5 actually kind of resemble the SOS knockout. So I think it was a natural idea to think, okay, maybe LRP5 would be one of the main receptors that sclerostin acts through. But there was a study in 2013 in Science Translational Medicine where they have knocked out LRP5 and then treated these animals with the antibody. And you see that no matter if LRP5 is there or not, you can always get this bone anabolic response. So this actually suggests that LRP5 is not like the most critical receptor for sclerostin actions. And the same group then went further to construct a double deficient mouse of LRP5 and 6 here in the DMP crease. So again, in more mature osteoblasts and osteocytes. And again, these animals were then treated with sclerostin monoclonal antibody or not. And you can see in the wild type that, of course, the sclerostin antibody has this nice anabolic response, but this was completely absent in the double deficient animals, showing that likely even LRP6 is one of the main receptors for the action or for the osteogenic actions of sclerostin inhibition on bone. This is just again the same study showing also again for the vertebral body. I think here you could also see it very nicely that bone anabolic response in the wild type and in the knockout completely absent. Overall, this also recapitulated or is in line with the older study that used in vitro systems to look at LRP5 and 6 binding. And here they had a different area of cell lines where they looked how radioactively labeled sclerostin binds to LRP5 or 6. And as you can see across all these cell lines tested, there was a stronger binding of sclerostin to LRP6 than to LRP5. And they also did another experiment where they knocked down either LRP5 or LRP6, and then again checked where you would see a stronger labeling of sclerostin. And only in the knockdown cells of LRP6, you could see that also the sclerostin signal was diminished, meaning again that LRP6 seems to be, or that sclerostin binds stronger to LRP6 than 5. Okay, the last aspect I would like to touch upon is the waning effect that we see also in animal studies. So here's a study where we see mice treated with a sclerostin antibody over time. And you can see that the strongest increases in bone mineral density occur at the first stages, but later on there's, like for example here between weeks 6 and 8, there's actually not an increase in bone mineral density anymore. And in this study, they wanted to look at what happens to the osteogenic response, and they have used P1NP, a bone formation marker, in the serum as a readout for bone formation. And maybe we'll focus on the dotted line first. So these are mice that just received the vehicle. So this would be the natural P1NP response over time. And then they had a group, which is here in black, where the mice have been treated with 5 doses of the sclerostin antibody. And after dose 3 and 5, they did a pre-sampling. So before they administered the antibody, they took a sample. And then 4 days after the dose, they took another sample and then measured P1NP. And the same thing they did in parallel with mice that just got 1 shot of a sclerostin antibody. Here again at the same time of the 3rd dose of the continuously treated animals or at the 5th dose. And what you can see quite strikingly, I think, is that the dose in the treatment naive mice is, or the anabolic increase of P1NP is very strong in the animals that got the sclerostin antibody for the first time, whereas this effect kind of weans, and it weans even more after the 5th dose, suggesting that there is something like an exhaustion happening in these animals. And what these authors then found is they looked into the bone tissue, into the expression of Wnt inhibitors, and found that virtually all Wnt inhibitors were increased after the sclerostin antibody treatment. And this is just, again, for the first bar, always shown for 1 shot of sclerostin antibody and the continuous one. And this is a finding that has, I think, meanwhile been recapitulated by many groups. So here also the study from the Amgen group, where they looked at ovariectomized animals treated with a sclerostin antibody, and they also found this increase, for example, now of DICOF1 protein and mRNA levels. And maybe just having a short detour now, going back to DICOF, because we all know that DICOF is also an important Wnt inhibitor, and it also binds LRP5. But as you see here in this graph, the DICOF antibody, even though it does increase bone mass in overactomized animals compared to the vehicle control, it's not quite as potent as the sclerostin antibody. And the question always was, why is that the case, even though they're like mechanistically so similar? And it was shown that, similar to sclerostin inhibition, also inhibiting DICOF leads to a compensatory increase in sclerostin, as shown here in this study. And again, they have created very complex mouse models where they deleted DICOF and sclerostin at the same time in osteocytes. And maybe again, just focusing here on the micro-CT, you can see that even though DICOF deficiency alone has somewhat of an anabolic effect compared to the wild type, this can really be unmasked largely by co-deleting sclerostin. And in fact, the authors have chosen the word unleashing the osteoanabolic effects of DICOF inhibition by sclerostin, which I think is an appropriate term if you look at these graphs here. Yeah, DICOF knockout compared to DICOF and sclerostin, it's really a tremendous additional effect that you can gain here. And yeah, Amgen then has thought of, okay, maybe taking this a step further into a more pharmacological direction, and have created an antibody that can bind sclerostin and DICOF at the same time. And yeah, they have administered this to animals and can show that this heterodimeric antibody has more potent effects in increasing trabecular bone volume than a DICOF antibody or a sclerostin antibody alone. And it has a similar efficacy as administering a DICOF and a sclerostin antibody at the same time. And this was, again, mostly mediated via increases in the bone formation rate. So I think this could be quite interesting also therapeutically for the future, and we'll see where this goes. So this is already the summary slide. So I think here it nicely summarizes most of the effects of sclerostin on bone. So on the one hand, we've seen some of the data that demonstrated that sclerostin inhibits osteogenic differentiation already at the skeletal stem cell level. It inhibits their differentiation, and it even inhibits the progression of the pre-osteocyte to the osteocytes, which I haven't shown you today. I also haven't shown you that sclerostin can inhibit bone mineralization, or that sclerostin can induce osteocyte apoptosis and also osteoblast apoptosis. So those are additional ways how it can inhibit the osteogenic pathway. But we have seen data that sclerostin keeps these bone lining cells in a quiescent state, and that it can also stimulate osteoclastogenesis, most likely via the actions on osteogenic cells and the rank ligand OPG ratio. Yeah, and with that, I would like to thank you for your attention, and for all of those who miss traveling, show you some pictures of Dresden. Hopefully we will be able to travel soon and meet or see nice places again. Thank you.
Thank you very much, Martina. That was very interesting and a thought-provocative yeah, talk, something to think about also in the clinical context. So we'll now move back to the clinic, but in a different way. So our next speaker is Professor Kenneth Saag. He's a specialist in rheumatology, and he in fact recently became Division Director of Clinical Immunology and Rheumatology at the University of Alabama in Birmingham. Kenneth's research focuses on comparative effectiveness and safety of therapeutics, as well as methods to improve quality of care in gout and osteoporosis. And we're very delighted to have Kenneth with us today, because he's the lead author on the ARCH publication in New England Journal of Medicine a couple of years ago. So please, Kenneth, talk to us about romosozumab in clinical trials and practice.
Well, Bente, thank you so very much for the kind introduction, and welcome everyone. Good afternoon, evening, and morning. It's a real pleasure to be part of this great symposia honoring the late Professor Fleisch, and particularly to talk about some new developments in the development of methods and ways to treat osteoporosis. These are my relevant disclosures. And so you've heard really wonderful talks on the pathophysiology and on experiments in nature associated with sclerostin and the Wnt pathway. I want to just start off with my only slide on mechanism, and then really focus on some of the clinical data. But I think it's good in thinking about a monoclonal antibody to sclerostin, an inhibitor of an inhibitor, if you will, just to really review how this therapy is working. And so we've heard very nicely about how sclerostin affects both an increase in bone resorption through changes in cytokines and a decrease in bone formation through effects on osteoblast differentiation and activity. And you can see this illustrated in this cartoon. showing effects both on remodeling and, importantly, on modeling-based bone formation. Now, we think about modeling-based bone formation in a growing skeleton, and we think about it in the setting when someone is having a lot of loading to the spine. So this is different than most of our anti-osteoporotic therapies, which predominantly focus on remodeling. There can be some very modest effects on modeling with, say, denosumab or some of the anabolic agents, but the other anabolic agents, but not to the degree that we see with romosozumab. And then we also see over here the effects of sclerostin on increasing osteoclastic activity. So now, through molecular biology, we have a monoclonal antibody, romosozumab, which binds to sclerostin. And we can see the opposite effects, a decrease in resorption and an increase in formation. And so this is, again, mediated in the same way. And you first see a decline in some of these effects on formation, but also a concomitant decrease in osteoclast-mediated bone resorption, likely through Rankel pathways. Now, this may be, for those who are newer to this construct, the most important slide, because it really helps us understand how this therapy differs mechanistically from drugs that we're more familiar with. You can see both a marker of bone formation, P1NP, and a marker of bone resorption, beta CTX. Initially, in this phase 2 study, there's an increase in bone formation and then a plateauing effect, but a concomitant slight decline in bone resorption, followed by more of a plateauing effect. Now let's compare romosozumab with teriparatide, an analog of PTH, which is an anabolic drug, and that increases P1NP and to a lesser degree also beta CTX, and contrast it now with the most commonly used oral anti-osteoporosis therapy, the aminobisphosphonate alendronate, a decrease in bone resorption, but also a slight concomitant decline in markers of bone formation. So a therapy that's working really quite differently. And that was associated with these changes in bone mineral density. Now we can see throughout all these slides, romosozumab will either be green or light blue, and you can see teriparatide, TPTD abbreviation, and alendronate, and the very profound increases in bone density at the lumbar spine, at the total hip, seen with all the drugs, but preferential with romosozumab, even more improvement in bone mineral density than what we're used to seeing with teriparatide at the lumbar spine. Now I'm going to walk you through some data from some of the larger clinical trials looking at this therapy. The pivotal study was the FRAME study. This was the phase 3 study of over 7,000 individuals. You can see some of their characteristics here, and the outcomes of interest were new vertebral fractures at 12 and 24 months. We'll compare that with the ARCH study, which was more of a pragmatic trial, an active comparator trial, looking at a head-to-head study with alendronate, a slightly smaller study. Notice that the people in the ARCH study were older and slightly sicker. They had to have a fracture. Of course, somebody always sneaks in there, and when they go to adjudicate them, they didn't really have the fracture, but essentially everybody had had a previous fracture, and the outcomes are similar. And we'll also look at an interesting study called STRUCTURE, which is also an active comparator study, now comparing romosozumab with teriparatide, much smaller in size, and focused really on bone mineral density measured using DEXA and also quantitative computerized tomography. So first, let's look at FRAME. FRAME had a double-blind period of 1 year, and this is how the drug is commonly used. It's given for a year as a monthly shot. And then following the use of this therapy for a year, it's important to introduce a potent anti-resorptive drug, similar to the way we use teriparatide or abaloparatide, a period of time on the drug followed by a potent anti-resorptive afterwards. And you can see the inclusion, exclusion, and endpoints over to the right. So this shows the effects on bone mineral density, comparing Romo with placebo over the 12-month double-blind period, and very similar to the data I just showed you in the phase 2. very profound effects at the lumbar spine as well as at the total hip. In terms of the fracture endpoints, starting as early as 6 months, there is a trend towards a significant risk reduction. And clearly by 12 months, people randomized to receive romosozumab had a 73% relative risk reduction compared with placebo. So very significant effect on reducing new vertebral fractures. If we look at new first clinical fractures, also a risk reduction, and for non-vert fractures, a trend towards this with a nominal p-value of 0.03. Adjusted for multiplicity, it was no longer significant, but the trend is still in that direction. You'll notice, by the way, as we look through some of this data, we'll use the term nominal p-value. For some of the studies, the secondary endpoints did not undergo an adjustment for multiplicity, and so we need to be a little bit cautious in drawing firm conclusions, but the trends are all quite consistent in a protective effect on these different fracture outcomes. In terms of adverse events, the one thing we did notice, which is consistent with what we see with alendronate and denosumab with potent antiresorptives, is there were 2 events of either osteonecrosis of the jaw or atypical femoral fractures, which were seen on the Romo patient arm, but not seen in placebo. Cardiovascular events, which I'll have a bit more to say about, were not different in the FRAME study between the 2 treatment arms, between Romo and here a true placebo over the 12-month double-blind period. So these were the conclusions from the FRAME study: reduced risk of new vertebral fractures, reduced risk of clinical fractures. In terms of non-vert fractures, there was not a significant risk reduction at 24 months, and that caused a little bit of questioning and some consternation, since it was expected that this would occur. And when the data was looked at more carefully, there was a group of patients from South America who ended up experiencing a much lower baseline rate in the control arm of non-vertebral fractures than would have otherwise been anticipated. And so it's possible, although we don't know for sure, that the study was somewhat underpowered for non-vertebral fractures. And you can also see that some people will experience some injection site reactions since this is given parenterally. Let's look now at the ARCH data. And this was a relatively pragmatic design. Again, a year of treatment in a double-blind way against alendronate. Now here, no placebo in this study. And then following this year of double-blind treatment, everybody received alendronate. And this was an event-driven study. So it was based on the number of events and on a certain duration of time on therapy. You can see the median time on study drug and some of the other endpoints that were assessed. Now, keep in mind, we're comparing with alendronate, a very potent, efficacious therapy, and even against alendronate, as early as 12 months, there's a relative risk reduction in new vertebral fractures, and at 24 months in particular, a 48% risk reduction compared with alendronate. And this includes now the period of time in which people have switched from Romo, if they were on it originally, to alendronate, or in the alendronate arm continued on that. We saw similar effects here for this other co-primary endpoint of clinical fractures, and even against an active comparator, a risk reduction in non-vert fractures and hip fractures without an adjustment for multiplicity. But the trends are clearly quite favorable for this therapy, irrespective of how you define fracture endpoints. Now, here's where things got a little bit interesting, in that the study involved adjudication of cardiovascular endpoints with a potential understanding that romosozumab might have some cardioprotective benefit. But in fact, there was a 0.5% risk difference in cardiac ischemic events and cerebrovascular events as well. So that's 1 in 200 in terms of that overall risk. So this generated a good bit of discussion by the regulatory authorities. You can see from a couple years ago now, when the FDA in the US reviewed this, they ended up voting very strongly in favor of registration of this drug, although they did recommend a black box, so-called black box warning around this potential cardiovascular safety signal, and that appears in the product label. There was a lot of discussion at the time of this meeting about what this meant. And these were some of the comments that were exchanged at the advisory meeting. That the incidence rates were not dissimilar from other population-based cohorts. There was not clinical data, as we saw very nicely from Professor Rauner's talk, of developing problems in populations of humans that have the natural experiment of sclerostin deficiency, although regrettably many of these adults don't live all that long, and that there is not clear in vitro or animal data to explain this. And so this all was put into context in interpreting this signal. Let's look at a little bit more data and then turn back to this CV safety signal and provide a little more perspective on that. So here's the data comparing it with teriparatide, the so-called structure study. You can see the inclusion and the endpoints over here. 6 months, rather a year of Romo versus teriparatide. And what was quite intriguing about this study is that in addition to the typical bone mineral density measurement with DEXA, we also had quantitative computerized tomography, which allows us to separate out cortical and trabecular volumetric BMD. Overall, we see in light blue here, romosozumab compared with teriparatide, significant differences no matter how you look at it. But let me draw your attention in particular to this middle panel, where we know that when you administer romosozumab for the first year or so of therapy, you'll see a slight decline in BMD at some of the cortical sites, such as the distal radius. And here with romosozumab, we see preservation and, if anything, a slight improvement in bone mineral density at the cortical bone compared with the decline seen with teriparatide. So it's showing a real difference, if you will, and this may have relevance clinically when we're thinking about who to give this therapy to and how to make choices among our different drugs. The only thing to point out here is that with teriparatide, you will see some hypercalcemia, which is not seen with romosozumab. So the final data I want to share with you is just another study in men. In men, the regulatory agencies often request just a study comparing bone mineral density, and that's how this was designed. We can see compared with placebo that romosozumab looks good in terms of BMD in terms of men. Interestingly, there was a small numeric imbalance in adjudicated cardiovascular events here comparing Romo with placebo in the male study as well. So what do we think about this, this cardiovascular safety signal, and how do we interpret the results overall? In terms of overall safety, the events were generally balanced. There were some injection site reactions, some a very small number of cases of ONJ and atypical femoral fractures, but there were small numerical differences in cardiovascular adverse events in the ARCH and in the BRIDGE study. And there's 3 possible explanations. One is that, at least in terms of the large ARCH study, that alendronate may end up being cardioprotective. So maybe it's that we didn't look at it against placebo as we did in the large frame study where we didn't see this, but that maybe alendronate is cardioprotective. Could this be a chance finding in the larger frame study, although what about BRIDGE? And then is it possible, as I guess the regulatory agencies in the US and internationally have concluded, that this could be a real safety signal and we need to be a bit cautious in people that might be at higher risk? Well, here's data from the large Ian Reid experience with zoledronic acid and osteopenia, suggesting a decrease with the zoledronic acid in terms of myocardial infarction and a trend towards one also in composite vascular events overall. So that was a very interesting study and consistent with some of the early work by Ken Lyles in the studies that were done in developing the indication for zoledronic acid originally. This, however, is a meta-analysis across bisphosphonates and consistent with some secondary analyses of the old data with alendronate and with residronate. You see the overall point estimates suggest no protective effect of bisphosphonate overall. So we're not really sure what to make of that argument, but it seems that the preponderance of evidence points against a cardioprotective effect of the class of drugs as bisphosphonates. Maybe zoledronic acid is a little bit different, although that was not used in the studies we're discussing. Now here's where it gets even a little bit more interesting. And if you look at the curves of cardiovascular events in the ARCH study, what you see here is this very odd behavior of alendronate in the first month or two of exposure. It seemed that alendronate early on was actually somehow cardioprotective, an effect that had not previously been realized and doesn't really provide any pathophysiologic rationale. In contrast, there's a fairly linear, proportionate increase in CV events with romosozumab. And when we look now over the course of the full study, this is the period we just looked at of the first 12 months, we see that romosozumab did behave and did satisfy the assumption of proportional hazards. In contrast, alendronate had this very strange behavior early on, and then the event rate seemed to pick up a little bit over time. Moreover, when people were flipped over from romosozumab to alendronate, if alendronate was cardioprotective, you might have expected a slight decline in the event rate early on. So this has led people like Steve Cummings and others to question whether or not we're seeing sort of an odd possible chance finding in this larger ARCH investigation. So let me just spend a minute with you as time permits, and I realize we're running a little bit over and we want to leave plenty of time for questions, but I think it would be helpful to just illustrate how I use this drug in my experience with it since it's been approved now for some time here in the States. I think about it for patients with very bad osteoporosis evidenced by very low bone mass or history of past fractures, failure or contraindications to other bone therapies, no recent CV events, and the suggestion is none in the past year. And we want to make sure our patients fully understand the risks and benefits, and these should be discussed very explicitly. So here's a particular patient, 92 years old, has sacral alar fractures. You can see them on the CAT scan shown here. She's used alendronate in the past, has been doing some home rehab, has low bone mass. She's had a fairly normal metabolic evaluation. A little bit of concern is her slightly low PTH, although her alk phos was high. So despite her CKD, probably not adynamic at this point, but certainly a worry. So we had planned to think about either teriparatide or abalo, and ultimately selected neither of those due to out-of-pocket costs and plans to start her on romosozumab. She unfortunately had a fall prior to getting started on it, leading to a secondary fracture at her hip. And then finally, after rehab and into COVID, started on romosozumab, doing well now a year out, no further fractures, recently switched over to denosumab and continues fracture-free at this time. This is a rather sad case of a 55-year-old woman with anaplastic astrocytoma. She's not only had baseline osteoporosis, but has also received high-dose glucocorticoids and presented to me with severe back pain due to multiple compression fractures, which quite sadly are quite extreme and painful, and had low bone mass. Hard to know where she started. She hadn't had a bone density prior to the dexamethasone, but likely osteoporosis baseline, and was started on Romo with improved back pain 2 months later, completed 6 ejections. We decided to treat her with a shorter course due to some worries about her cancer progression, and then onto alendronate. And while we've been able to improve her quality of life, unfortunately, her brain cancer and the effects of the radiation have progressed, and she was placed on hospice last month. Lastly, an 87-year-old woman with some past medical history, remote use of risidronate, denosumab in the past. We had thought to continue her on this. Unfortunately, continues to experience fractures of her spine, had missed her denosumab during COVID by a couple of months. And we know that after coming off denosumab, we worry about the risk of fractures recurring. And we had recommended that she receive Romo. Unfortunately, there was some issues with understanding of risks and benefits, and she continued to go on to more compression fractures. Still not on therapy due to concerns about cost, willing to try denosumab again, but difficulties here in the era of the pandemic and with various challenges practically about getting some of our patients treated properly. And this is not as good a story as the other ones associated with a person who I would consider a very good candidate for therapy, but who never got on it. So where are we overall? You can see we have a variety of therapeutic options in osteoporosis, drugs that reduce remodeling, drugs that increase the bone through anabolic effects, and now this new agent, romosozumab, which has an effect on bone formation and some interesting concomitant effects on decreasing bone resorption. Danicata, $1 billion later, a cathepsin K inhibitor, is not under development due to cardiovascular safety. So thank you very much for the opportunity to talk about romosozumab. And I think at this point, Bente will turn it back to you and take some questions from all of you on the Zoom. Thank you.
Thank you very much to all three excellent speakers. And we have a number of questions. I will start. We have a question to Dr. Appelman from Dr. Dabalingham. So they want to know if you know of any gender-specific differences of coning of the brain in relation to sclerosis.
Yeah, that's a very interesting question.
Yes.
If there's any difference between genders, indeed. Quite frankly, we didn't see any differences. But again, group sizes are very small. If you saw in the presentation, the number of people who suffered from coning of the brainstem were quite low. So it's not really able to distinguish between those two features. But in general, if you look at the clinics, you see that both males and females suffer in the same amount.
Then we have another question from Dr. Ree. So they want to know if there are any signs of increased tumors in patients with SOS mutations. And he also wants to know, I mean, this question can also be answered then his second question from all three speakers. It's about romosozumab and it only being applied for 1 year. So this could be also something which all three could address. If there's any rationale for repeating romosozumab.
I can speak clinically to some of the clinical data that we have. The drug is licensed for just a year in the US, and the practical challenge is getting it paid for longer than that. There is phase 2 data. The original phase 2 data looked at a second course of Romo, and I regret editing out that slide from my talk, but I was concerned about the timing and ran a little long as it was. But I think we do have some clinical evidence that you could give it again with some effects on bone density. And so that's encouraging. You know, we know that with teriparatide and abalitide, we have the so-called anabolic window, and that may close over time. We don't seem to see the same thing as much with romosozumab, so I think there is some interesting opportunity, although we saw some animal data that suggested maybe it's not as profound with the second course.
Would you like to comment, Dr. Rauner?
No, I think I'm fine. Or, yeah.
Okay, you agree.
Yeah. Can I maybe ask an additional question for you, Ken? Because when you look at all the data, and we are, you know, with these severely affected patients, we are into sequential treatment anyway. It's not like they're going to stop treatment right away. So could there be any idea, instead of giving a full year of Romo, maybe giving like half a year? Because although I agree with you, it's not like there's a complete closure of the anabolic window, but you still have that impression that there is something special going on during the first 6 months with a lot of bone formation and a lot of increases in BMD. So do you think there could be any idea in maybe kind of slicing it up, saying giving 6 months and then maybe 2 years of alendronate or zoledronate, and then maybe try again with the second course of a half a year?
I think it's a spectacular point, and it makes tremendous pathophysiologic sense to me anyhow, in terms of how we probably should be using our osteoanabolic drugs overall. That it probably ought to be a period of time on therapy followed by an anti-resorptive and then re-challenging later on. There is data that Felicia Cosman has generated with using teriparatide in that way, and I think that is a strategy that is gaining popularity, albeit not not proven by well-designed, large enough studies with fracture endpoints. And so that would really be a lovely study to do internationally. We need to find a fairly large budget to do that. I don't know who's going to pay for it, but yes, I think trying to look at the cycling on-off drugs like Romo with shorter periods of exposure followed by anti-resorptives makes a great deal of sense.
Okay, thank you. And maybe Dr. Appelman to address the point about tumors in these patients, increased tumor incidence.
Yeah, so we didn't see any increased risk for specific types of tumors, especially not for bone tumors. Of course, within the limited amount of patients we've been encountering, it's difficult to say, but we also did a very extensive chart review, also family history review, and also within the families, and these are often quite large families. They didn't experience any increased risk for any type of malignancies.
Okay, thank you. I have a question for Dr. Rauner. So first compliments on the talk, and then if you think the effect of anti-sclerostin antibody on a resorption, if it's mediated by primarily OPG, or do you think that it's mostly a direct effect on rankle, increasing rankle?
Yeah, I think that's a good question. And I think the data in that respect, at least preclinically, are not plentiful yet. So at least according to the study that I showed that used the cell line, they showed both direct effects on rank ligand expression, but also on inhibiting OPG expression. So suggesting it could have direct effects on rank ligand, but there's really not many studies on that. So I think more studies will be helpful, maybe to look at bone tissue of the mice themselves that were treated with this to get more direct measures in vivo. So I think we'll have to see in the future what the data bring.
Okay. We have another question from Dr. Kahler about Van Buchem diseases, patients if they have increased osteoarthritic signs. And maybe I would have an add-on question to Dr. Saag in his experience about osteoarthritis, and what would be maybe his hypothesis after Martina showed the preclinical data that could be that sclerostin inhibition could be detrimental for osteoarthritis.
Yeah, so for answering the question relating to the patients with Van Buchen's disease, we did have 2 patients already with early osteoarthritis of the hip and of the knee. But again, these were also patients doing relatively hard labor. And it's very difficult to distinguish, of course, the difference between the fact that they are, their joints are more they have more weight on their joints than just it's a causative effect of the lack of sclerostin, because we didn't see any increase for any complaints or any problems with hand arthritis or on non-bearing bones. So it's difficult to state that, but we haven't encountered it yet.
Yeah, it's an interesting question, and we of course don't have enough data of people with osteoarthritis and rheumatoid arthritis who have been treated with this drug. Ultimately, data will inform our understanding better. Could there be an increased risk of things like spinal stenosis? And I think there was some very interesting provocative data presented about potential exacerbation and RA disease activity. I think Ellen Gravelese has also generated some data on this as well. I think we really are going to need to follow that. I will say, though, that the people who were thinking about giving romosozumab to clinically are, if you will, are bone disasters. These are people that have really got very, very severe osteoporosis, and oftentimes they'll consider risks around a drug like this, if it exists even, given the severity of their problem and often a lack of other good options. So it's, we're always balancing benefits and risks in all our therapeutic decision making.
But may I ask, should it be so? There is now this whole new idea of starting osteoanabolic treatments even in patients that are not so severely, I mean, fracture-wise, influenced. So
Yeah.
what would your thoughts be
You're
on that?
You're right, and it ties in a little bit to Professor Langdahl's comment earlier that, if we could use these drugs in a more cost-effective way, maybe we could get our healthcare paying authorities to agree to use branded expensive therapies early on, and it would make therapeutic sense for some patients. And it might be a very short course that is followed by cheaper generic therapies. So yes, there is, the Endocrine Society in the US has put out some guidance suggesting that for people at high and very high risk, there is an argument to be made for using an anabolic therapy first. And we know they work better when they're given early on. Another circumstance where often use of an anabolic makes sense early on is steroid-induced osteoporosis. Now, romosozumab has not been tested or approved in that setting, but it would make some sense there, again, with the caveat we're not really sure what it might do in rheumatoid arthritis. And those are a lot of the patients, by the way, on glucocorticoids long-term. But that's another interesting population that we should be thinking about for earlier use of anabolics, given the effects on osteoblasts and osteocytes direct toxicity of glucocorticoids.
Bente, do you want to?
There's a couple of questions, and also something that is like a mystery to me, because it seems in the preclinical models and also to some extent in the patients with Sclerosteosis and Van Buchem, there seems to be a continuing effect of this low level or absence of sclerostin. There's a continuing increased levels of bone formation, whereas it levels off when we give it to adult elderly patients with osteoporosis. So I guess it's a question for all of you. So how can we figure out why there's this difference between our patients and what you see in the sclerostosis patients and in the mice and rats?
I defer to my more fundamental science colleagues if they can script together a mechanistic explanation. But simplistically, one always wonders about the mechanism of delivery. And if we, for example, were giving this as a continuous infusion, to me, the analogy might be hyperparathyroidism and giving parathyroid analogs. When you give PTH in a pulsatile way, it's profoundly anabolic. And when you have continuous exposure, it's catabolic. And so maybe there's some difference in how we administer the monoclonal. Now, it does stick around a bit, so it's not like it's gone completely between the time that it's injected every month and when you give the next shot, but it's certainly not physiologic in the same way that a person with sclerostosis would presumably have a persistent absence of it.
Yeah, I think it's a really interesting point also from my side, especially the use of the antibodies, where you see this so strong increase in bone formation. And to me, I always wondered if it's maybe an exhaustion of either the bone lining cells or the active osteoblasts, or even that not enough stem cells can be generated in the time that it would actually maybe still increase bone formation more if there was enough resources, let's say. But I mean, the studies that I've showed to some extent also suggest that they actually do promote the number of skeletal stem cells. So maybe that explanation is actually not so likely. But looking at the curves, I always feel like it looks like the bone and the osteoblasts in particular are kind of exhausted after some, like you can push them a lot, but they need some kind of recovery. So
can I just ask you, Martina, and maybe I didn't pay attention enough, but has that been investigated in young mice and in older mice? I just, you wonder if the pool of pre-osteoblast or precursors are just smaller just because you get old, and that's when one of the differences we see.
I think that for sure could be an explanation. I mean, most of the studies that looked at these also repeated doses were younger/adult mice, but for sure not old mice. And I think for the stem cells, also the skeletal stem cells, there were many studies that showed that the numbers do decrease with aging. And we know also P1 and P, the bone formation markers, go down with aging in mice and humans. So it is possible that maybe there are not enough active osteoblast or even bone lining cells that can become reactivated again. But I think the aging studies probably even in mice are a bit underrepresented, I guess, given it takes a long time to do those studies. But yeah.
Thank you. Very, very insightful. There's another question to Professor Saag. They want to know if there are any concerns data about romosozumab-induced severe hypocalcemia in advanced kidney disease. And I would have maybe an additional question to this, because advanced kidney disease we know is also associated with quite a high cardiovascular risk. So the question would be if these patients would be good candidates for romosozumab.
Yeah, no, I think it's an interesting question, and needless to say, in the anecdote that I presented, we successfully got away with doing this, and it seems to be working well. So in an N of 1, I would say it looked okay, but that's about the lowest level of scientific evidence that one could provide. We do have some pre-injection plans to check calcium levels before we give this therapy and assure that people are, not hypocalcemic at the time. That's part of our standard protocol. I'm not aware of any large-scale data that suggests that it's a particular concern, but we're certainly aware of that with denosumab being a big worry in people with advanced CKD. So it's not as potent and anti-resorptive as some of these other agents. So I guess maybe I'm less worried about it. I'd be interested in hearing whether Bente has any knowledge or experience in this, given her extensive use of this therapy as well, and being involved in some of its investigations too.
No, in fact, there's been done a post hoc analysis of frame and arch, dividing them into levels of kidney function. Of course, there were not many patients with CKD4 in any of the trials, but even across the other levels of CKD, there were no indication of an increased risk of hypocalcemia. And we haven't seen it in any of our patients either. And I think it's maybe because at the same time, you stimulate bone formation, and usually with teriparatide, we also see a tendency to increases in calcium. So anyway, we haven't seen it. So yeah.
I would agree. We have another question for Dr. Rauner from Dr. Haridi. So this is on the decrease of marrow adiposity through sclerostin inhibition, and they're interested to know about the mechanism, direct effect on sclerostin produced by bone marrow adipocytes, or any metabolic phenotype associated with sclerostin antibodies in mice. So this is looking into another aspect, also very interesting. Yeah.
Yes, no, there are definitely studies coming from Ryan Riddle's group that looked into sclerostin and glucose homeostasis and metabolism. I think the effects are rather slim in my opinion, but there seems to be something there also by looking into LRP4 deficiency, which kind of like promotes SOST actions. So with the antibody, I'm not sure if there were detailed studies done, to be honest, but in genetic models of SOS deficiency, definitely there seems to be additional effects in addition to just the modulation of the skeletal precursor cells. But as I said, I think the effects are maybe, let's say, secondary. I think they're not so strong, as you might expect from a bone-derived factor.
Okay, so we have plenty of questions. I think there will be not enough time to address all. I think all three speakers would be available also after the webinar to contact them personally for these very, very interesting questions that we still have. But I think all in all, we had really interesting and multifaceted session going from the human disease to Bente's side, and then again to the human studies. So a lot of aspects were touched upon, and thank you to all the speakers for really state-of-the-art talks and also the interesting discussion. And I would now ask Bente to close the session.
Yeah, I also, on behalf of IFMS, want to thank all the speakers. It has been an excellent session in my mind, and it really shows why we should never have meetings with scientists and clinicians separately. We need to be in the same room because that's the only way we can really develop this field. So I think this afternoon has been a really good example of that. So thank you very much, and also thank you to Elena for organizing this and sharing this together with me, and also thank you to all the participants. And